Welcome to all of you, and welcome everyone to this Mentor-Mentee session. As you know, we are lucky to have here with us Dr. Diane van der Woude. She holds a staff position at the Leiden University Medical Center, and she defended her PhD on anti-citrullinated antibodies on rheumatoid arthritis.
Thank you very much. Please do call me Diane.
Okay, thank you,
Yeah.
Diane.
So I am originally Dutch, as you can tell by the name, and I grew up a little bit, mostly in Holland and a little bit in the United States, then moved to Germany for my medical school in Heidelberg, spent a year in Boston performing basic immunology research in a lab during medical school, and after medical school returned to the Netherlands for my rheumatology training, and I did a PhD combined with that rheumatology training. That is actually rather common here in the Netherlands, that you can get several years off during your specialty training to do a PhD. That was 3 years in my case. And as you already alluded to, I mostly investigate, and I still investigate, risk factors and autoantibodies for rheumatoid arthritis. I've also started performing a little bit of research into ANCA-associated vasculitis recently. And since 2015, I finished my training and stayed on as a rheumatologist here in Leiden, where I see patients, do some management tasks as head of the outpatient clinic, teach, and of course perform my research with several PhD students now, still focusing mostly on autoantibodies. And I'm very honored that EMEUNET decided that I'm senior enough to be a mentor today. Wow. So I hope I can provide you with some useful advice, and I'm very glad that you all wanted to join.
Thank you very much. I'm sure you will. Okay, so now is the time for mentees to have a little introduction. So if you want to start, Arani, can you tell us something about yourself?
Sure. So, hi everyone. My name is Arani. I am a academic clinical fellow based at the University of Manchester in the UK. So I've completed my medical training, and in August I'm going to start my rheumatology specialist registrar training. In part of my job plan, I have some academic time, so I've been working with Professor Will Dixon on projects related to digital epidemiology, so studying patients' rheumatological conditions using digital methods like smartphones and watches. Going forward, I'd like to apply for funding for a PhD fellowship, and in the long term, I'd like to pursue a clinical academic career in rheumatology. So it's great to meet you all, and I'm looking forward to hearing about your experiences, Diane, and learning some tips for the future.
Thank you very much, Arani, for this nice introduction. Minnie, if you want to tell us something about yourself.
Yes, hello everyone.
Yeah.
I'm Mrinalini, Minnie for short, and I, like Arani, I'm an NIHR funded academic clinical fellow, but I work just next door in Liverpool, so also in the UK. I am at the same stage, so I have completed my general medical training and will now be going on to be a rheumatology registrar in August. I completed my medical training in Cambridge, and I did a little bit of immunology projects there, but I discovered epidemiology when I started working with Dr. Marwan Bukhari just after my medical school. And so now I am focusing on infection in rheumatic diseases, and going forward, I'd like to pursue a PhD combining my two loves, so epidemiology and immunology in the context of infection in rheumatic diseases, and take that forward into a PhD, hopefully within the next sort of 2 to 3 years. So yeah, at the minute I am doing a project on looking actually at biomarkers for hot joints in the sort of septic arthritis arena. So something a little bit different. But because of COVID, it's been put on hold. So now I'm focusing a bit more on the epidemiology at the minute. Thanks. I'm looking forward to learning lots from all of you, particularly Diane. Thank you.
Thank you very much, Minnie.
I'm Mohammed Hassan, lecturer of rheumatology in Vivekanantham University, Egypt. I just finished my PhD in rheumatology. My interest in rheumatology and rheumatoid arthritis, osteoarthritis, osteoporosis. I am also a member of Prento Egypt, a subgroup of Prento. We are interested in pediatric rheumatology And I think the clinical research is a very important issue. I hope I get the benefit from this. Oh, I am very happy to join you. Thank you.
Thank you, Mohammed. David, can you tell us about yourself as well?
Hello, everyone. My name is David. I'm from Mexico, from the northern Mexico, from Monterrey. I made my medical school here in Monterrey, and then internal medicine. At the same time with internal medicine, I had a master's degree in medical science. Then I do 2 years for rheumatology here in the University Hospital of Nuevo León. And then I made a PhD. I have a clinic in a public hospital, and also have private practice, and also made some research. I am very interested in the antibody profile in the rheumatoid arthritis patients and how this can affect their prognosis in already treated and diagnosed patients, because there is so many new profile, many new autoantibodies in the patients, and I would like to know if we can use them in already diagnosed patients. That's my interest. Thank you, Diane, and thank you, EMEUNET, for the invitation, and I hope we can learn a lot. Thank you.
Thank you for assisting, David. Thank you very much. I think that we have another mentee that was scheduled to the previous meeting, but we're lucky to have him here as well. Akpabio, can you tell us, can you present yourself?
Hello, everyone. I'm really happy to be here. So I missed the other group. I got the timing wrong, but I'm happy to be in this other group as well. So I'm a rheumatology fellow here in Nigeria. I am trained in adult rheumatology, and I finished last year. I joined the EMEUNET meetings last year as well, where I met Diego and co. So I'm happy to be here again this year. In terms of my career, I think I'm sort of at some sort of crossroads, trying to decide, do I proceed with clinical medicine more, or do I do more of research? So that at the moment I'm involved in lots of research, lots of collaborations. I co-chair the patient, I co-lead the lay summary subgroup in the Global Rheumatology Alliance. So I'm doing lots of networking and so on and so forth. So I hope I'll get to learn a lot today as well from Dr. Diane. Thank you.
Thank you very much, Akpabio. Now it's my turn. I'm Diego Benavent. I'm a rheumatology consultant from Spain. I just finished my residency last week, actually, and I started my PhD on axial spondyloarthritis. I'm working I'm collaborating in the EMEUNET and the peer mentoring working group. And well, I have participated previously as a mentee in some of the mentor-mentee meetings, and I'm really glad to be here sharing some time with Diane and with all of you that I'm sure it will be like a nice time for everyone. So Diane, if you agree, we can start with some small questions to break the ice, okay?
Yeah, sure.
So first, we would like to know something about, a little bit more about you. How and when and how did you start working on rheumatoid arthritis?
I started working on rheumatoid arthritis after I did 2 years of general medicine like training, specialization.
Okay.
During medical school, I already decided I would like to do something with immunology. Mm-hmm. Also because of this year I'd spent in basic immunology research. And I took out several different subjects during medical school. I did internships in rheumatology for one of them, infectious diseases and other things. And then I thought, I'm not sure about rheumatology. I'm not sure that's exciting enough in the long run. Maybe I'll be an infectious diseases specialist. And with that idea, I started my general medicine training. And on the go, I discovered that in infectious diseases, it wasn't quite what I had been looking for, because I discovered I really like to do outpatient clinic and see people come back to me with their problems. Where in infectious diseases here in the Netherlands, either you treat the pneumonia or the UTI and you never see the patient again, or they have HIV. And that is actually a rather small population here in the Netherlands. And those were not the only patients I wanted to see. So I thought, oh, maybe I made a wrong decision. I need to think of a broader subject. And that's how I came back to rheumatology. Mm-hmm. And luckily here in Leiden, it was a deliberate choice for Leiden, where there was a very prominent rheumatology department. And one of my colleagues whom I was working with in internal medicine had done a PhD in this department, and he really fired my enthusiasm for the rheumatology department here at the LUMC and said, why don't you apply and see what kind of projects they have? Mm-hmm. And that is how I ended up over here studying rheumatoid arthritis.
Okay, very interesting. Thank you. And we have some other questions regarding rheumatoid arthritis. Some more specific questions. So we go. As new rheumatoid arthritis autoantibody has been described, for example, anticarbamylated, do you recommend to use them in the already diagnosed and treated RI patients to be reevaluated for increased risk of radiographic progression or decreased function?
I think currently there are no data to support that you can really clinically use these extra autoantibodies when you treat rheumatoid arthritis. There are publications that show that anticarb positive patients have more radiographic damage. That is true, but there have also been several elegant studies that have looked at whether they really have an additive value when you already know rheumatoid factor and anti-CCP status. And then it turns out that the extra group you identify that would be anticarb positive, so we say anticarb for these anticarbamylated protein antibodies, that group is actually so small that there is not a lot of additive value. So I think you can, if you take rheumatoid factor and anti-CCP into account, you have a pretty good impression of who is likely to develop erosions, and the additive benefit of anticarb is not large at the moment.
Okay, thank you. Well, now that we have started with the hot topics, we go with another questions on RA. Yeah. What can you tell us about autoantibody avidity and their implication in established and untreated RA? Meaning that could this predict DMARD de-escalation?
Yeah, I think there are several answers possible to that question. I think from epidemiological point of view, and I've heard that several of you do epidemiological research, so I think we can all appreciate the value of those data. I think there are good studies showing that the seronegative patients are more likely to achieve drug-free remission in the long run. So it is a prognostically favorable subset. There are, on the other hand, no treatment studies showing that you should really treat seropositive versus seronegative RA differently. To the best of my knowledge, there have not been studies that have stratified patients and then deliberately tested whether treatments might be more effective in one subgroup versus the other. There have been studies, and I have the impression this is becoming more popular in trials these days, to only include seropositive patients, especially in some biological trials that has been done, apparently with the idea that maybe then you get a more homogeneous population, for example. And I think pathophysiologically that makes sense, since we are still a little bit in the dark about what is really going on in seronegative rheumatoid arthritis. And it is, of course, more difficult to be certain of the diagnosis when you diagnose seronegative rheumatoid arthritis. So I think it is important to take the sero status into account, and it is likely that your tapering of your medication will be more successful in the seronegative group, but there are no hard data from randomized controlled trials that you should really treat seropositive versus seronegative RA differently from the start, to the best of my knowledge.
Thank you, definitely. So in this regard, I find it very important to do further research, keep investigating, and for this intent, it is important we understand to do multi-center research. So
Yeah.
in this sense, we've received a questions. How do you think can we join this kind of international multi-center researchers, especially as really junior researchers?
Yeah. Yeah, I think that's a very good question, because indeed that will be key to your future career. Do never underestimate the impact of belonging to a network of people knowing you. That will make a huge difference. And to be honest, when you are a junior researcher, you need people who support you. If you are a junior researcher doing research almost on your own in your center, it is very difficult to get into an international network or to get into multi-center trials. What I would always recommend is finding somebody or a center that will embrace you and take you along in these initiatives. So looking for a rheumatology department in your country or close to you that you can join. Or if that is difficult in your country, I can strongly recommend doing a rotation or an internship or planning a research stay abroad, and in that way strengthening your ties to the leading centers in your area. And that might sound as a very difficult task, but actually there are grants that are given for exactly this purpose. There are also Euler Fellowships, and we have had several people here in Leiden who have joined us with these Euler Fellowships. For example, from Portugal, Pedro Machado, whom you might know, and also the current, I think he's still current EMEUNET chair, Alexandro Cipriano, was also here. And I think that really provides an enormous impetus and stimulus to your career if you have the opportunity to work very closely with well-known researchers for example, 3 months. And then you can always go back to where you're from, but it's much easier to then continue doing that research and to be part of international networks than if you have to establish that all on your own.
Oh, thank you. Thank you very much. We will comment on that later, everyone, but I'm sure everyone has a smaller question regarding to this.
Yeah.
We, regarding research, we receive another questions more related to publications, because publication obviously is an important issue in our clinical research. So how do you think is the best way to choose a proper journal and to avoid rejection? That was the question. It's difficult.
So first of all, a disclaimer: rejection is part of the game when you want to publish manuscripts. So I don't necessarily think that it is a bad thing when your article is rejected. Remember, if you get reviewer comments, those really form a chance to improve your manuscript. Never leave those, never neglect them or ignore them, but always take them along and change your manuscript before you submit it to the next journal. Because remember, the chances are very high that if you resubmit it to another journal, that reviewers will make similar comments. But let's say you have your manuscript and you're thinking, what journal should I submit it to? Well, then it's of course important to take into account what are the specialties of the different journals. Even within rheumatology, there is a bit of a division of labor going on between the different journals that you can get a flavor of when you look at their table of contents. So what you can see happening in these last couple of years is, of course, the Annals of Rheumatic Diseases have become our highest impact journal. And part of that is also by the very smart strategy that is chosen by the people who run this journal, by the editorial board and by the editor-in-chief. Because this high impact is in part generated because they publish a lot of recommendations and guidelines, and that creates a lot of citations, and that really boosts the impact factor. But that also means that part of this journal is to some point, you might say, reserved for probably high impact manuscripts. That is what this journal is looking for. So most likely that will not be a single center study, for example, or a one case control study. You will probably need to replicate your data and look for collaborators and make it into a larger study if you want to make a chance at that kind of high impact journal. And then you also have journals which are more focused on, for example, epidemiology. I always have the impression that, for example, arthritis care and research, which is a little bit dependent to arthritis and rheumatology, right? They kind of belong together. But arthritis and rheumatology seems to do also a bit more of the translational research, and arthritis care and research does more of the health outcomes research, more based also on patient outcome, on people being able to work. Those kind of epidemiological studies are more published in this other journal. And that is the case for other rheumatology journals as well, where you see Arthritis Research and Therapy doing more translational studies. And Rheumatology Oxford, I would say, does a little bit of everything. And coming to Rheumatology Oxford, it's also good to keep in mind that some journals originally had a national background. And Rheumatology Oxford, I feel, for example, has a bit more of a British background and is more likely to publish British Society of Rheumatology guidelines, for example. That can also kind of give a little bit of a flavor to a certain journal that's useful to know when you're planning to submit a manuscript.
Wow, really useful. Thank you. Now that we have talked a little bit about research, we already have some questions on the clinical side. So we receive a questions regarding the between clinical examination and history taken. Which do you believe to be the more crucial step in establishing a diagnosis in rheumatology? Again, a tough one.
Yeah, that is a tough one. I think that is not a black and white answer that I can give. It also depends a lot on the patient. We have lots of patients who can describe their complaints very well, and you then basically only have to verify that they indeed have polyarthritis, joint swelling, and you can take it from there with the additional investigations like lab and radiology. But of course, occasionally we also have patients who have more difficulties with expressing themselves correctly, who know that they have pain but have more difficulty putting it into words. And then our physical examination is definitely key, because we of course need to know, is there really inflammation or is this more widespread pain? And that really is then decisive in determining what we can also do for a patient. I don't know if you've had more experiences in these last weeks with video consults, for example, as well. We have been discovering that here in Leiden as part of this COVID pandemic. And we sometimes see real advantages. We can see patients in their home environment, and it gives you useful information, like, for example, a guitar lying around that a patient needs to use their fingers in a certain way. But it also has its limitations, because you just cannot feel the joints, and then they still need to visit our clinic so that we can find out what's going on. I think in the end, we always need both.
Yes, definitely. But so have you started already video consultations in Leiden? Do you usually do it established for any kind of patients or not?
Yeah, that is something that is a key question indeed. What is the best kind of patient to offer a video consultation? I think we're figuring that out as we go along. We were lucky in the sense that another department in our hospital had been working very hard on these video consultations already before COVID emerged. And we could just kind of jump on board a running train and establish these video consults. And we offered them to a lot of patients at first, but then discovered that many patients actually preferred to stop by our clinic, to actually speak to a doctor face to face. So we're now trying to figure out, in my personal experience, it's often, of course, more younger digital native patients who are very happy to get a video consult so that they don't have to come, especially if they already have a diagnosis for a couple of years and they know what to expect from their visits. Sometimes we also have referrals where the diagnosis is pretty clear cut, where the GP refers to us saying the patient has osteoarthritis, what can you do? In those cases, a video consult can also basically be enough and be satisfying for patient and for treating physician. But if somebody is referred to you with just a diagnosis of pain, I feel we usually just need a physical consult to figure out what's going on.
Yes, definitely. In this sense, we got a question that is quite related to this, I think, and maybe you have some insights. They ask, do you feel there is something in particular that could and should be changed in the rheumatology practice in your country?
Sorry, I couldn't quite catch that last part. Something that should be changed?
In the rheumatology practice in your country.
That's an intriguing question. Well, before COVID, I would have said we could do more distance consults. We could do more video consults. Now that has been kind of sped up due to this whole pandemic. Well, I think something, but that's perhaps not typically to the Netherlands, but for, I think, rheumatology practice in many countries. I think we can still make much more use of e-health. And in an ideal world, I would envisage that patients, when they have an appointment scheduled, that they could log on to a personal medical environment. They could indicate how many complaints they have, what they want to discuss, and whether they feel that they need their clinic appointment, or that we could, for example, have a video consult or another way to discuss that. And that in that way, we could shape our clinics from going from the old-fashioned way where all patients had to come in to get their advice to a more of a hybrid kind of structure where patients also get to decide whether they want to come or not and how they want to get their consultation, be it in person or be it via digital avenues. I think that could be really the future for our profession, where we have more channels along which to communicate and we're not so stuck in our physical clinics.
Yeah, definitely. I totally agree with that. E-health has to start to be a reality, not only a hope for the future, but a reality now.
Yeah.
Thank you very much for all your really nice and enriching answers. Now we have time for 3 questions. I'm sure everyone has a lot of things that want to know and want to ask. So if there is any brave that wants to start, anyone has any questions for Diane now?
Could I ask a question?
Yeah, sure, Arani, thank you.
Thanks very much, Diane, for sharing your answers to our questions. It was really helpful to hear. My question is around how you balance all 3 of your aspects, your clinical work, your research. You also mentioned that you do some teaching and supervising PhD students, and also like family and social life. Do you have any tips or advice, especially as a trainee wanting to kind of have a similar structure going forward?
Yeah, I think what has helped me personally is generally, it is very important to take time to reflect on what your goals are in each area, and then to actively act upon that and structure your days and your weeks in such a manner that they allow you to attain those goals. So I think that we doctors are very prone, very susceptible to being caught up in our days, and there are more patients to see, and there are phone calls to answer, and then there are emails pouring in, and at the end of the day think, now what have I done, and didn't I want to work on this manuscript instead? So what has helped me a lot personally is to always think in advance. I as many Dutch people, I bike to work, and on my bike every day I think, so what is it that I really want to do today? And I make a to-do list and I put that on top. And that sometimes means that I do not answer my email immediately, because otherwise I can never finish that manuscript that I'm working on. And usually most emails can wait a little bit. And that's why it's email. Otherwise they would have called you if they needed an answer immediately. And I don't just do that per day, but I also try to do that looking at months even in advance. And I try to make lists of, well, sometimes it can also be family related that gets first priority. If a family member needs to move and you decide to, that was in my example, that was the case, and you decide to help that family member move, then that is the top priority for the next weekends, for example. But it helps me also retain some kind of calm amongst all the tasks, because it also helps to, if something then is not done, it's okay as long as you decided that it was not your top priority. In the end, we all have to live with some tasks not getting done. That's usually the way it is. But as long as you decided that that's okay, that that task might not get done, then you can live with it. And at the same time, you can focus on what is really important for you at that moment in your career.
Okay, so you mean to prioritize and to really focus on the deep work that you have to really work on, and then let everything else for later, let's say.
Yeah.
Okay. Thank you.
And it can also help, of course, to again, so I have been very much supported by people in my department. If you feel overwhelmed or you have too many tasks, it can also always help to ask advice. Some people will just help you prioritize. Other people can open your mind to what are, wise long-term decisions. Generally, for example, in research, it is wise, especially when you're starting out, to really focus, to take a topic and do that topic. And I have, for example, I've received the advice many a time to pick a disease. Don't try and think you'll do something interesting in rheumatoid arthritis, and then I'll also do lupus, and then I'll do SPA, because that will usually not work. One cannot be an expert, a master of all trades. That's usually not how it works. And it will also not help your career in the long run, because you will need a recognizable profile. People need to think, I know Arani, and this is what Arani does. And if you've done lots of different things, it's far more difficult to build a recognizable profile in the long run.
Really helpful. Thanks very much, Diane.
Is there anyone else who has have any question?
Yeah. Thank you very much. Already I have two questions. First, about how to avoid the effect of quarantine on our research. It's a very important issue. My second question is about hydroxychloroquine. Hydroxychloroquine nowadays has a very large dilemma, but I think from rheumatologist view, I think it's further safe drug. What's your opinion about hydroxychloroquine at its usage and its dilemma now? Okay, thank you.
So let me start with the last question. Regarding hydroxychloroquine, I think it is a drug that we've, of course, been prescribing for decades. Well, not me personally, that's not how long I've been in rheumatology, but I think the field of rheumatology has been prescribing it for decades. And overall, the experiences have been good. And there are known safety issues regarding retinopathy and maybe some cardiac issues. But when you look at the rheumatology literature, it seems this has not been a major obstacle to using this drug also long-term in many patients. It has now gotten more attention, also the topic of cardiac failure due to hydroxychloroquine in this COVID era. But there was a very nice presentation, and that's the good thing about this online EULAR, you can still see it, by the group of Elena, and she has a very difficult to pronounce last name, Maya Sayedova, I think from Mayo Clinic. It was on the first day, on Wednesday, who did a very nice case control study in our A patients with heart failure, and looked at whether the patients with heart failure had received more hydroxychloroquine, and that did not appear to be the case. So I think overall, we can be relatively reassured about the safety of hydroxychloroquine for our indications. And then your first question was about the impact, and that I could not quite understand auditively. The impact, could you say it again, of what?
Oh, okay, the impact of quarantine in our research. Yeah, this is
the impact of quarantine. You mean that our patients don't come to clinics anymore? Yeah, that is a big topic. That is a big topic here in Leiden as well. I think that is something that we have to find a way to deal with. Obviously, many ongoing recruiting trials will suffer from the fact that we all, our patients and physicians, we all cannot be as mobile as we used to be. if you have the chance to still make a choice on whether you want to start a trial or whether you want to do another kind of research, now might be a good time to do a retrospective study or something for which the data have already been collected, because obviously inclusion is going to be an issue for a while. And I think there is no way around that. I think we're all bound by our institutional guidelines about who can come and who cannot come, about guidelines regarding collecting of biomaterials, and we'll just have to take this in stride. There's no way around it.
Okay, thank you.
Thank you, Mohammed. Okay, anyone else wants to ask a question? Maybe Mimi? Okay, thank you.
Yes, thank you, Diane, for sharing with us today. So I have two questions. First of all, as someone who's quite junior, looking to do a PhD and probably needs quite a lot of guidance in many different areas, how would you suggest choosing your supervisory team? I have like the 1 or 2 core people already, but obviously there's like 3 other gaps potentially that I could fill, and they'll obviously be able to suggest as well, and there's obvious choices, but what do you look for in a supervisory team when you're doing a PhD? And the second question I had, which was maybe a bit controversial, but again, as someone very junior, I'm starting to take up maybe some leadership roles now, but as someone junior and also as a female, I sometimes struggle to assert myself in large groups because I just feel I don't have as much experience as the people around me. So what would you suggest as tips in that situation to help?
Yeah, thank you. Very diverse questions. Yeah, I can understand that they're very current for you. Regarding the supervising team, I think there are several things that I have found useful. I would try and see if you can find people with different skills. It is always useful to have, of course, different mentors or supervisors who can complement each other. So people with expertise in slightly different areas who can give you also a different point of view. And that is, of course, that is not only for your own personal development, but I have also discovered it is very practically helpful when it comes to manuscripts, for example, because sometimes you and your first supervisor will agree that the manuscript is looking well. And if you then ask somebody who's a little bit further off, they will come with exactly the comments that reviewers are likely to make. So it really can increase the chances of your manuscripts getting accepted if you have somebody whom you can approach and who is willing to look at your manuscripts and give you a little bit of different feedback. That really helps a lot. And what is also very important, I feel, in selecting supervisors or people to work with is experiences from others whom they have supervised. And that was also key to how I got here in rheumatology in Leiden, is that I spoke to several people who had worked here and who said, you know, that is a really nice department. People help you, they do high quality research, but it's also a good place to work. It's not all about competition. People are not unkind. I mean, sometimes you have famous people who are just not so into teaching or to supervising, and then it doesn't do you much good to have them on your team. People also have to have a little bit of an altruistic or mentor kind of approach, that they're willing to share their information with you. So always try and find other students who maybe can recommend which supervisor is really helpful in the long run.
Thank you, that's helpful, yeah, thanks.
And then about our position as young females, I still see myself a little bit as a young female sometimes. I think it differs a lot. I think it also differs a lot on what people expect of you. I've worked in different environments. I did my medical school training in Germany, and in some environments, for example, in general in Germany, people are a little bit more formal. And I sometimes feel that they also, in this more formal, perhaps a little more traditional environment, they do not then necessarily like young females to be very assertive. So it can be useful to try and feel a little bit in what kind of environment you are. And if you feel that there are more traditionally minded people there, then it's always useful to speak up in meetings so that people will know that you're there. But then it can also be useful to not make the impression that you're overly forward, and it's so often it's in subtleties like adjusting language, like starting your remark with, perhaps I can ask a question, and think, oh, this is a nice girl, you know, she's not too overly aggressive in this meeting. And in other situations, though, don't get me wrong, you won't need that at all. You can just raise your hand and you can participate like anybody. But it's often good to get a feel of what people are expecting of you and what they're looking for in the role in which you're participating in this meeting. And what I can recommend, for example, maybe you already know that, but EMUNET is a wonderful organization anyway, but one of the best things about EMUNET is that they have these observerships in all kinds of EULAR committees and EULAR task forces. And I think that is very useful to get a feel of how these task forces or EULAR committees work. And I would definitely recommend doing an EMUNET observership because you're really a part of that committee. But that is, for example, often a little bit of a position where it's sometimes wise to be a bit of an observer, as the word already says. So to make it's good that people know that you're there, but nobody expects the observer to be in the lead, right? That's not what people generally expect of you. And lastly, about female leadership, I myself read a book a couple of years ago. It's a quite well-known book called Lean In, from, maybe you know it as well, Cheryl. Yeah, I thought that was a helpful book. I mean, you don't always agree with all tips that you get, but there were some things in there. And for example, I like the title, which basically says, if you find something that you really like as a female, then don't hesitate when you're at the board table to lean in and give your opinion instead of leaning out and waiting for others to do the work. That's not what we ladies should do. We do let's need people know that we're there and that we want to participate.
Thank you. That was a really comprehensive answer. Thank you so much.
You're welcome.
Really helpful.
Thank you, Diane and Mini. Thank you very much. Maybe David and Akpabio, do you have any question?
Yes. Thank you, Diane, for your answers. I am wondering if when we publish and the journal asks for the recommended revisers, reviewers, does it work? Or I don't know, does work for the persons who we don't know, we don't want to review our work, or the other way?
Yeah, I see what you mean. And thank you, David, for joining, because I think it must be really early where you are.
Yes, 5 o'clock, 5 o'clock in the morning.
Wow, that's amazing.
Not for me, but so it's okay. It's okay.
Yeah, so the questions about the recommended and the non-recommended reviewers when you submit your manuscripts. Yes, I do feel editors take that very seriously. What you need to know is that when you submit your manuscript, it will be passed on to a sub-editor, somebody in the editorial board. And one of the most challenging tasks for these sub-editors is to find reviewers. Right? That these sub-editors are expected to have an enormous network and to know everybody's specialty so that they can divide these manuscripts evenly over the people who probably have expertise and can give them a valid opinion. That is actually really challenging for the sub-editors. So if you provide them with recommended reviewers, it is in fact rather likely that they will take your suggestion and at least take a look at whether that reviewer might be eligible, you know, if it's not your best friend, to review your journal, and the same to review your manuscript. And the same is true for the not recommended reviewers. I think there are lots of groups who have some friction or some competition here and there. The editors are aware of that. And if you feel that somebody is biased or likely to give a negative judgment about your manuscript, they will, I think the sub-editors, they will not send your manuscript to those reviewers. And that's exactly the reason why that question is in the submission process, because people know that this can be a problem and they want to give the manuscript a fair chance. So it's worthwhile to spend some time thinking about which names you want to enter in those fields, because it really can make quite a difference in the reviewing process. I always still discuss it with others as well. Which names shall we put in there? During my PhD, I always asked my supervisors, because it can make quite a difference for the way the reviewing process works out for your manuscript.
Excellent, thank you.
Thank you very much. Thank you, Diane, David. Akpabio, do you want to ask anything?
Yeah. Okay. Thank you very much, Diane. I've learned a lot from what you've said so far. How do you handle rejections? Let's say manuscript rejections. How do you stay motivated? How do you pick up yourself and resubmit? And how about when research is not going your way, like your lab research and so on, you're not getting what you expect? How do you keep going in such situations?
Yeah, that is indeed the key characteristic, resilience, that we all need in our research careers. I think it differs a little bit on how hard the adversary circumstances are, of course, how one could best deal with it. I think when manuscripts are rejected, what I have been very actively taught here in Leiden is not to feel too saddened or dejected myself, but to ask, what can we learn from this? What can we learn from why the manuscript was rejected? And it is a very useful exercise to keep repeating that to yourself. Also, when it comes to, for example, abstracts at meetings. So why was my abstract not selected? Or why was it made into a poster instead of an oral presentation? What made this abstract that was selected for an oral presentation, why was that different? And if you do that, if you do this exercise for yourself, and you discuss it with your colleagues as well, then often it becomes more easy to understand why the decision turned out the way it did. Now, of course, there sometimes are blatantly unfair decisions. That also needs to be said. That does happen. And maybe it's also good to mention that there are appeal possibilities. I didn't know that when I started writing manuscripts, but I have discovered that there are colleagues who appeal quite frequently if their manuscripts are rejected. You can write letters to, for example, the editor-in-chief and say, I think a mistake was made. My manuscript was so important and these reviewer comments were so unfair that I would ask you kindly to perhaps reconsider and see if there should not be perhaps another judgment about my manuscript. Now, of course, you need to be careful and choose when you want to use that option. But if you really feel that it is very unjust and that the reviewer comments don't really apply or were not made in a fair manner, then this is something that you can consider. And I know that people get into high-ranking journals like The Lancet using this strategy, in fact. And this is not as uncommon as you might think. With lab research, here too, the question is, what can we learn from a failed experiment? And sometimes, and there can be different conclusions. Often it's in the methods, and it is something technical that went wrong. You need good supervisors to point that out to you and to help you on your way. Sometimes, of course, the hypothesis does just not seem to be true, and it is important sometimes to also be able to decide to stop doing something. If something continuously does not work, then maybe it will also not work in the long run, and it is important to be able to decide that in time, but not too early, to avoid working for a very long time on something that will not give you any really results in the long run. And here, again, I would emphasize talking to others. Always try and see if you can find an expert either within your institution or also at another institution. People are often very helpful if you just send them emails, if you look at their publications and you write to them and say, I'm trying to replicate this, or I'm trying to do something similar and somehow it does not work. We've exchanged protocols via email and that kind of thing. That can be very helpful to decide on whether to give it another shot or to call it quits for lab projects.
Thank you very much, Akpabio and Diane. We have still 5 minutes. If there is anyone that have any other question, if not, is there anyone that has any? Okay, so then I have one question as well, since as I told you, I'm just starting my PhD. I wonder if you had the opportunity to tell yourself any single advice to yourself before you started your PhD, what would it be?
I think it would be part of this advice that I just already mentioned, to see if things do not go your way, to find out what you can learn from that. Because often we see younger people, indeed, they're more easily disappointed than the more senior researchers. Mm-hmm. And I think that is not just because the senior researchers have already built their careers and they're more confident that they won't lose their job or anything, but that is also experience. A little bit of disappointment is part of the game, also of research. And it is a key feature of a researcher to make the best of things and not feel too disappointment, or to not throw away the project too easily, but to really analyze. I think that is the main thing, to really analyze what went wrong, why is it not working, how can I improve it, whom should I ask for advice, and how can I still make the project be successful. So try and keep asking yourselves those questions instead of thinking that I'm just desperate and this will never work. That is, in the end, it's about knowing that, so disappointments are part of the game, and try to use them in your favor to improve your project. In the end, it's always just about improving things so you make the situation as optimal as possible as you can in your situation, with your supervisors, in your country. And then I think you can do a lot of interesting research in a lot of different circumstances.
Thank you very much, Diane, for your answer and for your time. I think it was a good conclusion for a great meeting. I really enjoyed myself. I hope you all did, and especially you, Diane. For us, it was really special to have you talking about not only about rheumatoid arthritis, but also about research, about clinical, about how to build our careers, giving us tips on resilience. I think it was really enriching. I don't know if any of you want to say anything, or Diane, you want to say any final word?
As a final word, something I haven't mentioned yet, but what a mentor once said to me in an EMEUNET Mentee mentor meeting back when I was the mentee. Somebody said to me, it's important to do what makes you happy. Try not to think too much of what will build your career, what might make you famous in the long run, but nothing will work if you don't feel inspired by it, if you don't really like what you're doing. In the end, you have to feel happy about what you do every day. That will suit you best and that will work best for you.
Oh, thank you. That's a terrific message to end. So I just want to thank you everyone for your participation, and I hope we see each other around next EULAR or wherever. But thank you, and it's really nice to meet you.